Good morning, everyone, and welcome to today's Journal Club. I've got two very interesting talks again today from one of our NCAS PhD students, Karen Venchik, talking about antifungal stewardship. And first up, we'll have Robyn giving some feedback about the GP NAPs that we did earlier this year. Thank you, Robyn.
Thanks, Rod. My name's Robyn Ingram. I'm a clinical pharmacist and I'm also the NAPS program manager here at NCAS. Today I'm presenting the results of a pilot study that we undertook last year, which was looking at adapting the National Antimicrobial Prescribing Survey to the general practice environment. So our aims for this study were to develop a data collection tool that was customised to the GP context, and also to create a report that GPs would find practical and that would give them meaningful feedback about their antibiotic prescribing. In the longer term, we hope to establish a method of collecting data that would inform local quality improvement at both a clinician and a local practice level, and to identify targets to inform future work and research, such as reasons for non-compliance with endorsed guidelines and inappropriate prescribing. Looking at the bigger picture, we also wanted to provide evidence for jurisdictional and national programs and responses as well, if we could, with the data that we collected. So this was just a small pilot study. We had 11 practices that elected to participate, and they were located in metropolitan and inner regional areas on the east coast of Australia. We collected 50 patients worth of data for each practice, which gave us just under 600 prescriptions overall for analysis. And the way that we did that was by going on site. So we had a trained auditor go on site with a paper-based data collection form to extract as much data as they could from the medical record. And we felt that was very important because while almost all GPs are using an electronic medical record system, the diagnosis or the indication for prescribing an antimicrobial is not consistently recorded in a designated place within the medical record. And in addition to that, prescribers can use their own medical terminology or abbreviations. So because of these limitations, it's not possible to use passive data extraction systems to try and pull out all the data that we needed at this point in time. So hence it was very important to us that we went in person, had full access to the medical record, and really left no stone unturned in terms of extracting all the data we needed. And that's exactly what we did at the end of last year during the data collection phase. Once we had collected the data, it was obviously de-identified, and then it was presented to a multidisciplinary panel for review. And the panel consisted of an infectious diseases physician, a general practitioner, a clinical microbiologist, and a clinical pharmacist. So the data we collected some fairly basic patient demographic data, mostly focusing on the types of things that could influence a prescriber's decision regarding the choice of antibiotic or the dose. We took all the details around the antibiotic prescription itself, including whether the prescriber had indicated in the medical record that the script was intended to be a delayed prescription, meaning that we didn't expect the patient to actually go and fill that prescription unless their condition failed to improve or indeed deteriorated within a set time frame set by the prescriber. And we also looked at whether a repeat prescription was provided with the original as well. We collected all the relevant microbiology around the patient that may have been taken, but we also went further than that and went into quite extensive detail in terms of collecting the clinical notes for the patient. We looked at their past medical history, what medications they were on, if they'd had antibiotics in the past, and if so, for what conditions and how frequently. And if necessary, we even went further than that and looked at radiology and other test requests, professional communication between clinicians, anything that we needed in order to get a full picture of exactly why an antibiotic had been prescribed. And the last thing we were looking for was to see if the indication had been documented by the GP in the medical record, and if so, to take note of that. But we did sometimes find that in some cases it wasn't really clear, and that was one of the reasons why we wanted to make sure we'd collected as much information we could about the patient's presentation to the GP, including the clinical exam findings from when the GP examined the patient. And that was because if we couldn't find the indication documented, we wanted to be able to pass all the information we could across to the expert panel to see if they could determine the indication for the antibiotic, which would then help us with our further assessments. So at this point in time, I'd just like to mention a few limitations of this study. Obviously, it was a small study just looking at a handful of sites to give us an idea of where we can go in the future with this type of general practice NAPS. We restricted our research to systemic antibiotics only, and unfortunately we were unable to determine if there were patients who had presented to their GP with an infective process but who had not been prescribed an antibiotic. And that's one of the limitations, I guess you could say, of the current prescribing software, is that GPs can free text the indication for the antibiotic into the medical notes. And that means that when we come in as researchers, it's very difficult for us to search through that program in an organised way and be sure that we're collecting out all the information that we need and that our records will be complete, because the GPs could document anything for the indication. And so it's very, very difficult to search. But in the future, we hope that that would be something that we could look to address, and certainly that would have been ideal. We know very well that GPs are often giving verbal or potentially even handwritten instructions to their patients, but we couldn't record that as part of our study because we only had access to the written medical record. And unfortunately in Australia at the moment, it's not possible to link the prescription that would have been given to the patient to dispensing data at their local pharmacy, or even to hospital data to see if there was any further patient follow-up or outcome as a result of their illness. But we hope that those data linkages might become available in the future. So moving on to the results. When we looked at the indications that GPs were commonly prescribing antibiotics for in general practice, we found that there were really no surprises. Respiratory tract and ear, nose and throat infections, skin and soft tissue infection, and acute cystitis made up the top 4. We found that 77% of prescriptions did indeed have an indication recorded by the GP in the consultation notes on the day of the patient's visit. That was one of our criteria, but it was not necessarily in the fields that you would expect. Some GPs had put the indication in the reason for the patient's visit and some in the progress notes, and that was usually the case, but often we did have to go searching quite far and wide to find the indication, sometimes on a radiology request slip, sometimes in a discharge letter from a hospital. So it was very important that we did have access to the medical record to be able to get that additional information. And that turned out to be very useful when we did give that information to the expert panel, because they could then determine the indication for 96% of prescriptions, which was great. So we could then progress to looking at our assessment of guideline compliance once the indication for the antibiotic was confirmed. And we were looking to see if GPs were prescribing in line with the therapeutic guidelines or other widely accepted guidelines such as the Royal Children's Hospital guidelines or women's guidelines, women's hospital guidelines. We know that these guidelines are freely available online and that GPs will often Google for them and find them. We also asked GPs if they were using any locally endorsed or jurisdictional guidelines, but none of the practices were using any that we could determine. So the next step was to look and see if there was any directed therapy that was going on, which is where a GP might give an antibiotic in response to microbiology results that have come back for the patient. There were also some cases where the prescribing didn't appear to be compliant with the guidelines, and there are also some times when there is no real guideline for a particular indication that a GP might be treating. In a small number of cases, there wasn't enough information recorded in the medical record for us to be able to do a guideline compliance assessment, and those prescriptions were considered to be not accessible. So when we looked at the results for overall guideline compliance, we found that they were quite low, just 21% for the compliance with the therapeutic guidelines, and the non-compliance rate was quite high at 67%. But what is important to recognise is that our criteria for assessing guideline compliance are incredibly strict. So not only does the GP have to pick the most appropriate antibiotic for the patient's condition, but it has to be at the right dose, the right frequency, and for the right duration. And to get all of those criteria right, that's what's required in order to have an assessment of compliance with the TG. So it is quite difficult to meet. And when you consider that some of the practices we went to, 3 of them in fact, didn't actually even have access to the therapeutic guidelines, you can see that they were already on the back foot because we were assessing them against a guideline that they couldn't even access. What we did find though was when we looked at something that GPs did have very ready access to, which is the MIMS, and that's available with a simple click through their electronic prescribing software, we found that the compliance rate was much higher. And in part, that's because the MIMS, being a compendium of product information supplied by the manufacturer, is much more general in terms of the dosing recommendation and advice it provides. It's mostly geared towards therapeutic approval processes, but it does provide some information for practitioners about how to give antibiotics, but the recommendations are often very broad. So, for example, it might just say that an antibiotic can be used for respiratory tract infections, but obviously we know there are lots of different types of respiratory tract infections, including some viral ones. So we wouldn't want an antibiotic to be given for those. So we did find that when we looked at the MIMS compliance, it was much easier to be compliant with the MIMS. So then we progressed to the appropriateness assessment, and what we have here is basically a quality assessment of the prescription overall as judged by the panel, and where the panel felt that the prescription exactly matched the therapeutic guidelines, or if the GP was prescribing in line with advice that they'd received from a specialist that the patient had seen, then that prescription was deemed to be optimal. Sometimes we found that a prescription only just fell short of being compliant with the accepted guidelines, or alternatively that the GP had prescribed something else that was also a very reasonable choice for that patient's condition, and those prescriptions were assessed as being adequate. We then combine those two categories to give an assessment of appropriate. Sometimes a prescription is written where it was considered by the expert panel to be too broad for the indication, or perhaps the treatment duration was excessive, and those scripts were categorised as suboptimal. And we sometimes have a situation where we actually feel that the patient could potentially come to harm from the prescription, and that could be the case where there's been a significant allergy mismatch, there was no antibiotic treatment required at all for the patient's condition, or where the spectrum, dose or duration of the antibiotic is actually unlikely to treat the causative bacteria that the patient is likely to have as a result of their condition, and those prescriptions are deemed to be inadequate. And we then combine those two categories to give an assessment of inappropriate. So then when we went forward and did our appropriateness assessment of all the prescriptions, we found that when it was assessed by the expert panel, the overall appropriateness was actually much higher than what we saw when we assessed the prescriptions against guideline compliance alone, and it increased to just being under 60%. And that's one of the advantages of the NAPS methodology, is that it does take this extra step to actually do an assessment of the overall quality of the prescription, which obviously, as you can see, yields good results. But we do still need to remember that there are these prescriptions sitting over here that were considered to be inappropriate, and worryingly nearly 30% are considered to be inadequate. And it's important to go through and I think have a look at why prescriptions were thought to be in that category. But I thought first what I might do is show you the top antibiotics that we saw being prescribed as part of our study. So the number one was cefalexin, and I thought if I just talked about this, you might see how we went through and sort of did the assessments, and it would give you an idea for how things were done as part of the NAPS. So we found that cefalexin was mostly being prescribed for skin and soft tissue infections and wounds, and for urinary tract infections. And in most cases, it was being prescribed in a way that was considered appropriate. But if we look down the list and skip down to amoxicillin clavulanic acid, which is the third most commonly prescribed antibiotic, we actually found that that was mostly being prescribed for respiratory tract infections and sinusitis, where it's generally regarded as being a second-line treatment option and not something that we would be giving to patients up front. And we were going through the medical record and looking to see if patients had failed their first-line therapy, but that was very rarely the case. And so these prescriptions were usually marked as inappropriate. We also thought it was quite interesting that GPs were prescribing quite a lot of macrolides, because at the moment the macrolides are not currently recommended through the therapeutic guidelines for the treatment of any condition, but they're obviously quite popular and still being prescribed. So where the panel did give an assessment of an inappropriate prescription, we thought it was very important to document why. And the number one reason why a prescription was thought to be inappropriate was that the indication didn't require any antibiotics at all. And this was mostly the case for upper respiratory tract infections, bronchitis and pharyngitis, where these conditions are often due to a viral process, and current recommendations are that they shouldn't be treated with antibiotics. We saw that there was a little bit of dosing confusion where an antibiotic could be used to treat multiple different conditions. An example would be cefalexin, where it can be dosed 4 times a day for a skin infection, but might only be dosed twice a day for a urinary tract infection. And we did sometimes find that prescribers mixed up the dosing for the different conditions because there's more than one option for that particular antibiotic. So maybe just a little bit of education required there. It was very rarely the case that the antibiotic prescribed was too narrow for the patient's condition. It was much more common that it was too broad, and we saw that quite a bit with augmentin duofort and cefalexin. And likewise for the duration, very rarely was the duration too short. It tended to be too long for the treatment course that we would expect. And we felt that this was really being driven by the pack sizes that are commercially available. How we did this assessment in the study was unless the GP had specifically documented on the prescription or in the medical record that they wanted the patient to take their therapy for, say, 3 days or 5 days, something quite specific, we assumed that the patient would take the entire pack supplied to them through their pharmacy, and that was indicated on the prescription. So we used that to calculate the number of days of therapy that a patient would have. And we know that community pharmacists will often add to any antibiotic prescription the instruction for patients to take it until all finished. And so that was another reason why we felt that there would be many patients out there who would follow that advice. And there were 2 other special categories that we looked at as part of the GP NAPs. They didn't actually influence our appropriateness assessment in any way. When we looked at each prescription, we just looked at it on face value, whether it was a delayed script or whether there were repeats provided or not. We just looked at the original script as it was. But we did think it was very interesting information to collect. And what we found was that a lot of prescriptions did have repeats provided with them, and if that repeat was filled, then there was 22% that would have been, 22% of patients would have been exposed to a prolonged treatment course, and about 10% of the prescriptions that we looked at were designated as being intended to be delayed prescriptions by the prescriber in the medical notes. So we were quite surprised at the high rate of repeat prescribing that we found in this study. More than 1/3 of prescriptions were accompanied by an additional repeat. And contrary to what you might think, these were not repeats where it was sort of long-term therapy and you're expecting 5 repeats to be given. Most of the time, the repeats were just for 1 additional repeat. They were often for respiratory tract or ENT infections, and they were often for cefalexin and amoxicillin clavulanate, which are 2 of the broader spectrum antibiotics that GPs have easy access to and can prescribe. And that was quite surprising as well, because the packets of cefalexin and amoxicillin clavulanate will generally provide enough treatment for 5 days, which should be an adequate course for most infections. So we were interested by that because to our way of thinking and in line with the therapeutic guidelines, a repeat prescription would generally not have been necessary for most patients. We did have a subset of GPs that took part in our study who were really great at documenting the duration of treatment that they wanted the patient to have for their course. And we looked at these prescriptions specifically where the patient had also been supplied a repeat. And we found there were 58 scripts that fell into that category. And for 36 of them, when we looked at them in more detail, the supply of the repeat appeared to be unintentional. And I say that because the repeat extended the treatment course for the patient far beyond the duration that had been explicitly documented by the GP on the prescription or in the medical record. So we started to think about that, and we felt that probably it was being driven by the EMR software default settings. At the moment, when GPs are in their medical record, the software programs are pre-designed to upload the maximum number of PBS repeats that the GP could prescribe to that patient. And that's a very useful feature if you're doing long-term chronic therapy and you want to give a patient 5 repeats with each visit so they don't have to come back and visit you all the time. But when it comes to treating acute illnesses where you really only want a one-off course of treatment, that could perhaps be problematic if we're getting the maximum number of repeats uploading. There were a lot of conditions that were prescribed well during the study when we went through and looked. Tonsillitis, skin and soft tissue infections, and urinary tract infections all fell into this category that had a high degree of overall appropriateness and a low number of repeats prescribed. But the same, unfortunately, cannot be said for the respiratory tract infections. We know that this is often a difficult area for GPs where perhaps there's less clinical certainty around the diagnosis, and also that GPs are really worried about potentially missing and undertreating an infection and the consequences of that. So when we went through and looked at a breakdown of the different types of respiratory tract infections that we were seeing, what we realised was that when we were seeing viral infections that had been documented, upper respiratory tract or bronchitis, the panel tended to assess these prescriptions as inappropriate for the reason that no antibiotic was actually required. And that's because these infections are often driven by viral illnesses. But when we looked at the types of infections you would normally find perhaps a bit lower down in the respiratory tract, pneumonia, infective exacerbations of COPD and bronchiectasis, The panel, we sort of saw that it was about 50-50 actually. About 50% of the prescriptions were considered to be appropriate by the panel and 50% inappropriate. Not because these conditions didn't require an antibiotic at all, but because the choice of the antibiotic or some element of the prescription was perhaps not as good as it could have been. And so we found that 53% of respiratory tract infections were actually assessed as not requiring an antimicrobial treatment. That probably contributed to the overall low appropriateness rate of 22%, but also there was a very high repeat rate associated with respiratory tract infections as well. So once we'd collected and analysed all our data, we got in touch with the GPs to organise feedback sessions, and these were done either through webinar format or by going to the practices in person. And we gave each of the GPs a customised report. So we grouped the results and we gave them their results for their specific practice. And throughout the report, this was also compared to the overall results combined. So they could see where they sat and how they compared to the other people who had participated in this study. Over half the GPs attended the feedback sessions, and we had the panel available to promote active discussion. We wanted to reflect on the overall results and chat about those, and we wanted to ask the GPs what they thought about the report that we had provided to them. Did they like the contents and the layout? What did they think about it, and how could we improve? So one of the questions that we asked GPs were, how would they feel about the possibility of participating in future audit activities and having the option to actually benchmark their practice, both at a practice level, so comparing practice against practice, and what about if we told them that potentially we could let them see their own individual results in terms of their prescribing and compare themselves to their peers. We were a little bit apprehensive about how GPs might find that, particularly when looking at their own individual results and having that compared to others. But in fact, the GPs thought this was a really fantastic idea. They were very enthusiastic about it, and they really liked the idea of being able to compare their results, particularly to other GP practices in their local area or to other GP practices that were seeing similar groups of patients to them. They felt that being able to see these types of results would be a really strong motivator for them to re-examine their own practice and potentially change it. And they also liked the idea that if they were taking part in audit and feedback activities and combining them with education, that they would be able to get a significant number of CPD points for that. So one of the other strong things that came back through the feedback themes was that GPs really wanted to know more about the performance of the different practices. So if I go back to the previous slide, you can see that there was quite a wide spectrum and a lot of variation in terms of how the practices were performing. And GPs wanted to know for those practices that were up at the top with sort of 65 to 80+% appropriateness, what were those practices doing differently? And could they emulate those practices and learn from them? So that was another strong theme of discussion. And what we did was we actually put together a tip sheet for GPs that they could use to quickly improve their prescribing and make sure that it was more appropriate. We discussed the access to the TG, and GPs told us that the lack of easy access was a barrier. They found the fact that they need to leave the electronic software prescribing environment to open their internet browser, log into a system which they have to have a subscription for and pay for that, search through that to find the indication that they want, look at the prescribing, and then go back into the electronic prescribing software. They did find that to be quite a cumbersome task. And it's particularly the case perhaps for GPs who've completed their training quite some time ago. The GPs that had completed their training more recently didn't find it as problematic, but some of the older GPs definitely said they found it to be an issue. And the GPs were also quite concerned about the software default settings. When we talked to them about how they were managing this situation, they said that really they were handling it on a case-by-case basis. When the patient was in front of them, they tried to remember to look at the repeats box and adjust the number of repeats they were giving that patient each and every time. But obviously in a busy clinic environment, it can be easy to overlook those kinds of steps when you've got a lot on your mind and a lot to do. So when we talked to the GPs, almost none of them realised that it was possible for them to go and alter the default settings in the back end of their computer. But in our experience, after this study, we've gone away and tried to look at doing that for some of the common prescribing software programs that are used. And it's not always straightforward and obvious exactly what you need to do. So it's perhaps not surprising that none of the GPs really knew that that was an option for them. So these are the clinical insights we gained from this research, and they also double as being the tips for GPs. We really wanted to try and encourage GPs to be proactive in documenting the the diagnosis for for each patient, or at the very least a differential diagnosis, and to try and do that consistently using consistent terminology and documenting it in a consistent place within the medical record. And we wanted to also try and prompt them to consider recording the indication on the prescription, because that really helps all other healthcare professionals that have contact with that patient. And it also helps the patient themselves. We know very well that particularly when patients are on a lot of medications, they often get confused about which medication is for what. So having it on the prescription in front of them and on the label on their box is very useful. We thought that GPs should get in touch with their prescribing software providers and find out how to turn off the automatic repeats. It's not just a case of turning them off as a blanket rule. You can actually customise it in some programs and have the repeats stay on for long-term chronic medications but come off for other acute medications such as antibiotics. And we wanted to impress upon them that commercial pack sizes are usually sufficient for a full course of treatment, and that repeats should rarely be necessary for acute treatment of conditions that they're likely to see in their practice. We saw that among the top performing practices, the GPs were routinely adding a stop or review date to their prescriptions, which meant that the patient was then very clear on exactly how long they had to take their course of treatment. And that avoids that problem, I guess, of pharmacists then adding and take until all finished onto the prescription, which may or may not have been intended by the GP. We saw that there were high rates of antibiotic prescribing, particularly associated with respiratory tract and ear, nose and throat infections. And in many cases, this was unwarranted. And so we thought that GPs should be considering carefully whether to prescribe antibiotics when they saw these patients presenting with conditions like that. And if they were going to prescribe, to aim for narrow spectrum antibiotics wherever possible. In general, we would recommend that flucloxacillin is prescribed for skin infections. And we saw that in this study, a lot of the time cefalexin was being used as a sort of a default alternative. And we let GPs know that really they should be reserving the cefalexin for patients that have genuine penicillin allergies and aiming to prescribe flucloxacillin as much as possible for these types of treatments. And similarly for amoxicillin clavulanate, we should be keeping that in reserve as a second line agent. Often when GPs were prescribing it, the increased breadth of spectrum that amoxicillin clavulanate provides wouldn't have actually been beneficial for that patient's condition. So the extra additional anaerobic cover or gram-negative cover really wasn't required for the way that the patient was presenting. In terms of insights into the documentation of the indication, we saw that some standardisation within the EMR is definitely needed to promote further auditing and feedback processes. And GPs want these processes, especially if they will be endorsed by professional bodies and eligible for CBD points. So it's up to us to find a way to help find a mechanism to support these types of activities that's sustainable. Obviously, the most sustainable way that will be both time efficient and cost efficient is if we can do it using passive electronic auditing methods. But in order for that to happen, we would need to have a much more standardised way of documenting indications within the medical notes so that it's much more predictable. We do also acknowledge that we're seeing more and more pharmacists in non-dispensing roles coming into GP practices, and also most GP practices do have clinic nurses as well. So while manual methods of data collection do remain an option, they are obviously very labour intensive and cost intensive as well. But that is something that could also be explored. And for our insights around the guideline compliance and appropriateness, the lack of access to the TG was definitely a problem. If we could improve the point of care access, it would really support GPs to improve their decision making. And the RACGP standards for general practice actually promote using therapeutic guidelines as a reference. So it would be good if we could really extend out the reach of the TG so that it was much more readily acceptable and much more readily accessible to GPs, the same way that it is to clinicians in hospitals. And these barriers need to be addressed, the barriers of cost and the barriers of accessing the TG within the electronic prescribing environment. There was high compliance with MIMS, which was not surprising given how easy it is for GPs to access it while they're in the middle of writing a prescription. But it doesn't really help GPs prioritise their choices regarding antibiotics when they've got a patient in front of them and they're trying to make those clinical decisions. And lastly, we found that assessments of appropriateness resulted in much better results than just looking strictly at guideline concordance alone. But it does require having full access to the medical notes and trained staff in order to be able to do those assessments correctly. So where to from here? After this study, we've actually gone on to look at working together with the therapeutic guidelines to see if we can do some work around trying to improve access to the therapeutic guidelines for GPs. And we're also looking at doing work, we've also nearly completed work, looking at ways that we could potentially standardise nomenclature in terms of the way that indications are documented for antimicrobial prescribing. And that's the end of my presentation. Thank you. Are there any questions?
Just, you said that skin and soft tissue treated well. Can I just clarify? We're looking at systemic application only, so topical we can't comment on.
That's correct. So just to repeat the question in case you didn't hear it online, Nolene was just saying that for the skin and soft tissue infections, we were only looking at systemic antibiotic use. That's correct. So we're looking at obviously tablets and capsules, things that patients would take enterally. And also we did have a very small percentage of injectables prescribed, but we were not looking at any topical treatment. So no creams, ointments, eye drops, patches, anything like that. So we didn't assess that as part of this study. And that was done because when you go into the GP electronic prescribing software systems, the way that the medications are categorised is quite unusual, some of the groupings. Depending on the software program that the practice is using, it can actually be not very straightforward to search through the notes and try and pull out those different antibiotics for different conditions. But they do, these programs generally tend to have at least one search function for systemic antibiotics, but not always for topicals. Hi, Cass.
Robyn, could you give everyone an idea of how many practices, how many scripts, how long it took in terms per patient, and perhaps reflect back on the sort of resources that we have used for the hospital nets?
Sure. So for this study in the GP surgeries, we went in and we had a trained auditor, which was actually myself. And obviously I've got quite a bit of experience doing auditing and reading through medical records and making these assessments and using the NAPS forms in general. So when I went in, I found that to do 50 patients per practice, which could result in slightly more than 50 prescriptions because some patients might receive more than one, that would take me anywhere from 6 to 8 hours. So it was looking at probably between 5 to 10 minutes per prescription, and it depended on how well the notes were documented within the GP record. Obviously, if the GPs had been very meticulous in their documentation, then the auditing was fairly straightforward and didn't take too much time, except for when the patient was genuinely complex. But in some practices, it was actually very difficult with the software that the GPs were using to record the indication accurately, believe it or not. And the GPs mentioned to me that they found this very problematic, and I also found it problematic as an auditor. And in those cases, it actually took a lot longer to go through and pull out all the information that was required. And how does that compare to doing a hospital assessment? I think in general, in the hospital environment, certainly in the areas where I've worked, the documentation onto the drug chart of the indication for the antibiotic tended to be quite good. And I also inherently knew the patients a lot better, so I found that I could audit much more quickly. But even if you didn't know the patients and you were going around auditing a hospital, I'd probably say it takes about the same amount of time. So you're probably looking at about up to 10 minutes per patient. So I'd say it's roughly on par.
So do you think that active surveillance is still going to be an important part of this work? We can't rely on passive surveillance at the moment.
At the moment, we definitely can't rely on passive surveillance. We would have missed an enormous amount of information if we had tried to do that. And that's because of all the inconsistencies, both in where the indication is documented in the medical record, but also in how it's documented and the nomenclature used. But obviously that's something we would like to look to improve. But even if we could have an excellent passive data extraction program, I think there would still always need to be some element of clinical oversight, particularly for the more difficult patients, and some element of maybe perhaps a final sign-off and a final appropriateness assessment being done by actual clinicians.
Thanks, Robyn.
Thanks. Any questions from online? Thank you very much.